So I want to welcome everyone to this Zoom session, which is the first one related to audiology. Hopefully you all had a chance to view the 5 presentations that were created at Michigan Medicine and that you found them useful. My goal for this session is to provide you with practical information about newborn hearing screening, including a background and rationale for universal newborn hearing screening and why and how follow-up occurs. Please feel free, as Mike said, to raise your hand with any questions along the way, and I will be posing questions to you as well. So these are the learning objectives. So I'm hoping that following this webinar, you'll be able to appreciate the evolution of newborn hearing screening over the years, understand how risk factors that place infants and children at risk for late onset hearing loss impact follow-up, appreciate the tools that are available for assessing auditory function and hearing in pediatric patients, and appreciate the role of the medical home in surveillance. So here's your first polling question. Permanent hearing loss occurs in A, 10 out of every 1,000 otherwise healthy newborns, B, 10 out of every 10,000 otherwise healthy newborns, C, 1 to 3 out of every 1,000 otherwise healthy newborns, D, 2 to 4 of every 100 graduates of the NICU, and E, both C and D. Okay, so we did pretty well on that one. The correct answer is both C and D. So, and this information was in the presentations that you were supposed to watch ahead of tonight's presentation. So if you responded that hearing loss occurs in 1 to 3 out of every 1,000 healthy babies, you are correct. And the incidence is much higher for 6 babies at 2 to 4 for every NICU grad, every 100 NICU grads. We'll talk a bit later about some of the genetic causes of hearing loss as well as environmental factors as we discuss those things. I can't advance my slide. Oh wait, got it. Never mind. Can you go back? Sorry, Michael.
Yeah, you just hit the up or down arrow, should send you back.
Okay, got it. Okay. Sorry, I'll get this by the end of the presentation. So we'll talk a bit later about some of the genetic causes of hearing loss as well as environmental factors as we discuss those things that place newborns and infants at risk. We know that hearing loss without appropriate intervention can negatively impact speech and language development. You can't learn what you can't hear, which can in turn negatively impact academic achievement, which can result in social isolation, and all of those things can negatively influence career choices and successes. The good news is that we know that if we intervene early, ideally by 3 to 6 months of age, children with hearing loss can develop language and have the same academic success as their normally hearing counterparts. So Marian Downs began advocating for infant hearing screening in the early 1960s and spent more than 30 years advocating for testing in hospitals and putting hearing aids on infants with hearing loss. Many consider her to be the mother of pediatric audiology. She died in November 2014, only 2 months before her 101st birthday. So we were lucky to have her influence our profession for so long. The Joint Committee on Infant Hearing Screening, or JCIH, was established in 1969, and that group was charged with developing more accurate methods of identifying hearing loss in infants. It was not until 2000, however, that the Joint Committee recommended universal newborn hearing screening prior to discharge and promoted a system for tracking and follow-up. The development of auditory brainstem response and otoacoustic emissions technologies were important contributors to being able to get physiologic measures of auditory function in infants and young children. Prior to that, audiologists had to rely on startle reflexes and observation of behavioral changes to screen for hearing loss. Early on, physiologic screening was only completed by audiologists on NICU babies, based on factors that placed them at risk for developing hearing loss. Moving to universal newborn hearing screening was controversial in the beginning, in part because of concerns about the cost-benefit ratio, and in part because of concerns that babies who passed initially, but who had risk factors for progressive hearing loss, might be missed. The list of risk factors has evolved over time and now includes separate risk factors for newborns and infants, and we will discuss both. Interestingly, the first position statement that in 1970 indicated that mass hearing screening was not justified. And the reason was that we lacked adequate procedures, which was true. ABR testing was first described in 1970, but was really not used clinically until the 1980s. Similarly, otoacoustic emissions were first reported in 1978, but they were not used clinically until much later. The 1972 statement outlined the initial 5 risk factors. 3 more were added in 1982, and 4 more were added in 1990. In addition, separate risk factors for infants as opposed to neonates were introduced in the 1990 statement. Each position statement became more explicit over time, not just in terms of risk factors, but also in terms of the requirements for a successful EHDI program. The most recently published statement was in 2007, although a new one is being finalized right now. It's actually finalized, it just has to be accepted by all of the groups that make up the Joint Committee. The 2007 statement was the first to include neural hearing loss. It also provided separate recommendations for screening in the newborn intensive care unit versus the well baby unit. It specified that rescreening should be for both ears, even if only one referred initially. It also removed the differentiation between congenital versus late onset risk factors. And here are the risk factors for neonates. And you can see on the left-hand column the first 5, and then the indication of which ones were added in 1982 and added in 1990. Family history of hearing loss is important, although it's tricky because some parents may not be aware that there is a family history of hearing loss. Examples of perinatal infections include rubella and toxoplasmosis. And rubella was something we didn't have to worry about for a long time, but now is sadly coming back. Examples of non-bacterial fetal infections include congenital cytomegalovirus and herpes. Craniofacial anomalies can include cleft lip and or palate, microtia, recessed jaw or micronaphia, and just to name a few. For hyperbilirubinemia, the level has to be severe enough to meet criteria for exchange transfusion in order to be a risk factor. Bacterial meningitis creates urgency in follow-up and intervention because it can result in ossification of the cochlea, which creates some challenges in terms of intervention. For exposure to ototoxic medications, the exposure needs to be greater than 5 days. The primary agent that we are concerned with is gentamicin, which is an aminoglycoside antibiotic. One of the things that is tricky about that is that some of the sick babies go on and off antibiotics during the course of their NICU stay, and we don't always have a really good handle on that. In terms of syndromes that are associated with sensory neural hearing loss, that list continues to grow as more genetic syndromes are identified. Probably the most common we see in our clinic is Down syndrome, although there are lots of other trisomies and other congenital abnormalities that result in hearing loss. Another frequently seen condition in our clinic is charge syndrome, which I'm not going to go into in detail. A separate category of risk factors for infants was added in the 1990 position statement. As you can see, parental concern is at the very top of the list. Other factors include head trauma, neurodegenerative disorders, and childhood infections such as measles and mumps, which also were pretty much eradicated until recently. Sadly, measles and mumps are coming back due to parental decisions not to immunize their children. There are several components to a successful early hearing detection and intervention, or EHDI program, as indicated here. It all begins with making sure that every newborn is screened prior to discharge from the hospital and that there is a mechanism to ensure that babies born at home are also screened in a timely manner. The second important component is the medical home, which really refers to a primary care physician or advanced practice provider and their team. The idea is to provide family-centered care that is accessible, comprehensive, coordinated, compassionate, and culturally effective. For those of you who are family members of individuals with neurodevelopmental disorders, you know this is a tall order and remains aspirational at this point in time. The third piece of the EHDI puzzle is having access to audiologists who have specialized training and expertise in working with children and who are able to quickly and appropriately intervene when hearing loss is diagnosed. Consideration of parents' goals and priorities for their child is first and foremost. Connecting families with the support that they need is essential. Early on, in Michigan Hands and Voices are just two examples of that support. Finally, there must be a way at the state level to track the screening and follow-up for all births. At Michigan Medicine, we also track all of our babies, their outcomes and risk factors for progressive hearing loss to minimize loss to follow-up. As I mentioned earlier, universal newborn hearing screening was controversial when it was first proposed, in part because of the concern that children who passed an initial screen yet had unknown risk factors for progressive hearing loss would be missed, and we would still have children with hearing loss that is diagnosed late. Pediatric audiologists are able to provide oversight of the initial screening process and provide diagnostic testing when the screening results in a referral. We are also able to work with our otolaryngology colleagues to obtain medical clearance for hearing aids and to move forward with referrals to early on and other supports. Things are a bit more complicated for babies who pass the screening and who have risk factors, some of which may have been unknown initially. For those children, the primary care provider is responsible for conducting periodic global screens and for supporting the need for follow-up hearing tests. The Joint Committee recommendation is for at least one hearing test to occur between 24 and 30 months of age, with more frequent tests for some populations. Our protocol is to screen every 6 months until school age, so we are clearly not following the Joint Committee's recommendation, and we think for some good reasons. All children who fail the speech and language portion of the medical home global screen should be referred to pediatric audiology. In addition, those children for whom there are parental concerns about hearing or speech and language development should be referred. Sadly, in spite of universal newborn hearing screening, we continue to see 2-year-olds with hearing loss that was not previously diagnosed in spite of parents expressing concern. For infants with confirmed hearing loss, a genetics consultation should be offered, as well as referral to a pediatric ophthalmologist and a pediatric otolaryngologist. In Michigan, medical clearance for hearing aids for children must come from an otolaryngologist. The reason for referral to a pediatric ophthalmologist is that there are some genetic conditions for which hearing loss and blindness co-occur, and the intervention decisions may be impacted by knowing whether a patient is just going to have hearing loss or whether blindness may occur as well. For infants, an objective standardized screening of global development with a validated assessment tool should minimally occur via the medical home at 9, 18, and 24 to 30 months. Infants who do not pass the screen and language portion of the speech and language portion of the screen, or for whom there is parental concern, should be referred for hearing assessment by a pediatric audiologist, as well as for a speech and language screen. And you can see them really emphasizing the need for referral if there are any concerns expressed. So in terms of who's responsible for what and relative to communication, the birth hospital is responsible for conveying the results of the hearing screen to the parents as well as making sure that the parents have appropriate information about any need for additional testing or follow-up. Information throughout the EHDI process should be communicated in a culturally sensitive and understandable format. Families should be made aware of all communication options and available hearing technologies presented in an unbiased manner. The birth hospital is also responsible for ensuring that each baby has a medical home prior to discharge. The birth hospital also has a responsibility to transmit hearing screening information to the medical home and to the state EHDI coordinator in a timely manner. The state, on the other hand, is responsible for having a data management and tracking system as part of an integrated health information system to monitor the quality of EHDI services and provide recommendations for improving systems of care. Also important is an effective link between hearing and educational professionals in order to ensure smooth transition and to determine outcomes for children with hearing loss. In Michigan, there are actually specific criteria for audiology clinics who want to participate in EHDI. The EHDI coordinator in Michigan does a great job of keeping track of babies, needing follow-up, and of actually hounding families until they follow through with recommendations. So here's your polling question number 2. Regular surveillance by the medical home includes A, screening of global development at 9, 18, and 24 to 30 months of age, monitoring auditory skill development, consideration of parental concerns, A and C, or all of the above. Wow, we did really, really well with that one. So the correct answer is all of the above, and 94% of you got that correct. So congratulations, and it helps me to know that you're paying attention. Okay, so now that we've talked about the role of the medical home in EHDI, I want to hear from you about what you think some challenges might be to this model. So please raise your hand to talk about what you consider to be potential barriers to using the medical home for surveillance as I've suggested. Don't be shy. And think about it from your own exposure to primary care, and it could relate to your professions as well.
Katie, go ahead.
Well, I think the parental concerns part, as far as that goes, a lot of parents don't know how to address that and how to address skill acquisition of children, I guess, and what to do, how the first step to take, things like that. So I think that might be a drawback.
Okay, good. Anyone else?
Sandy, go ahead.
I think some of the time, not all of our doctors, not all of our pediatricians are a medical home, and they don't do the follow-up that they should be doing. A pediatrician might say, as the parents say, my child, they're not developing their language. Oh, we'll just give it time. And they don't follow through. They don't understand the importance of actually following through on that hearing. Part of it, too, is locating the parents. I know I do the EHDI follow-up through work at the health department, and sometimes, the phone has changed, and trying to track them down, calling the Medicaid health plan, and seeing if they have any new contact information. So, they fall through the cracks, and you're hoping that the physician will pick up on that when they go in for their well child checks. You can't find them any other way.
Great. Anyone else?
Sarah, you had your hand up. Did you still want to comment or no?
Yeah, I was kind of going to go off what Sandy said.
Oh, okay.
On the same page, but just that physicians might not have the appropriate background in audiology, and so things might fall through the cracks there. And because hearing loss is relatively low incidence, they might not refer to an audiologist or otolaryngologist.
Great, thank you. Anyone else?
Jay, go ahead.
I just wanted to add to what Sarah and Cindy were saying. When they are seen by clinicians, I think, actually, I don't think it's limited to audiology issues, but consistency in which clinicians patients continue to see. Even at specialized medical facilities, if if the patients have to see different clinicians each time they go in, I think that could be a big barrier and challenge in the continued care for that patient.
Great. Anyone else?
No one else right now.
Okay. So here are some ideas that I had about it. So as Sarah pointed out, low incidence of severe hearing loss means that not all primary care providers are really aware of what to look for. Again, limited physician education on all aspects of hearing loss. There are some misconceptions about the success of universal newborn hearing screening. Sometimes some medical homes have trouble getting the results from the newborn hearing screen. They may or may not be able to have the ability to retest in the office. Family support is a concern, and working with early intervention and community agencies. And then there are time constraints and financial constraints that are potential barriers. So although universal newborn hearing screening was initiated in the 1980s, it was not until the mid-1990s that there was consensus that all infants should be screened prior to discharge from the hospital, that hearing loss should be detected by 3 months of age, and appropriate intervention should be initiated no later than 6 months of age. By 2001, most states had mandated universal newborn hearing screening or EHDI programs, although it remains the case today that there is some variability across states. Specifically, in some states, universal newborn hearing screening is only mandated in communities of a certain size or hospitals of a certain size. So while the 136 guidelines are those are our current standard, so screening by 1 month of age, diagnosis by 3 months of age, and intervention by 6 months of age. There is already discussion that those of us who are successful in meeting those guidelines should strive to move toward 1, 2, 3 in order to maximize the chances for success of these kids with hearing loss. So I like to talk just a little bit about auditory development because I think it's pretty amazing how quickly the auditory system develops and what babies are able to do at what ages. So the human cochlea is fully developed at birth, yet the central auditory pathways are not ready to go. Maturation takes over a decade, and there's some plasticity throughout life. So it's important to think about how hearing loss will negatively impact the development of auditory skills. The tuning of the auditory system begins very early. We know that fetuses are able to hear in utero by about 25 weeks gestation. Yet we also know that much of the high-frequency information in the speech signal is filtered out because of the acoustic environment. Suprasegmental information, such as intonation and rhythm, transmit very well to fetuses. However, the high-frequency information does not transmit well, which means that they don't have access necessarily to the specific acoustic elements in the phonemes themselves. Amazingly, fetuses and newborns are able to discriminate their native language from a foreign language and their mother's voice from that of another person. Infants attend preferentially to infant-directed speech over adult-directed speech. So there are a number of critical periods, the first of which is when babies try to master the sounds of their language. Initially, babies can discriminate all of the sounds of the world, so any language. However, sometime between 6 months of age and their first birthday, babies become selective listeners. They become sensitive to the rules of their own language. And by the first birthday, they are no longer able to discriminate sounds from languages other than their own. Also by their first birthday, babies with normal hearing and cognition are able to extract the salient features of their native language while listening to fluent speech. I think this research is amazing. It's remarkable to me that people can even study these things. Anyway, so when hearing loss is present, general cognitive skills may become more important to the achievement of successful language outcomes. Now we're going to move on to what options we have for screening babies. So there really are two technologies that are used for newborn hearing screening. Otoacoustic emissions involve providing sound into the ear canal through a little probe and recording the echoes that are generated by the outer hair cells in the cochlea. The difference between transient and distortion product otoacoustic emissions is both the stimulus and how the OAEs are displayed. For transient otoacoustic emissions, a click stimulus is used, while distortion product otoacoustic emissions use tonal stimuli. Specifically with DPOAEs, two tones are presented simultaneously into the ear, and actually what we're recording is a distortion product that's generated by the cochlea at a completely different frequency than the tones that we present. The Joint Committee recommends using OAEs as a first screen in well babies. The other technology is automated ABR, which involves recording nervous system responses to sounds presented through earphones. It provides information about auditory system function through the level of the brainstem. It does not provide information about processing a sound. And automated ABR is recommended for use in the NICU. I want to just, before talking about how screening often works in practice in terms of these technologies, it's important to talk briefly about auditory neuropathy spectrum disorder, because its existence colors the decisions that are made about screening protocols. ANSD is characterized by normal cochlear or inner ear function coupled with poor neural function. It has a higher prevalence in the NICU population, particularly in infants with very high bilirubin levels, extreme prematurity, and anoxia at birth. And that's why it's recommended by the Joint Committee. Automated ABR is recommended for use in that population. It may be associated with other peripheral neuropathies such as hereditary motor sensory neuropathies and Charcot-Marie tooth disease. Having said that, it can also occur in otherwise healthy babies and young children. It really is a spectrum because the origin can be any juncture along the auditory nerve. Most patients have bilateral symptoms, although it may be asymmetrical or unilateral. And speech understanding in these kiddos is typically poorer than expected based on hearing levels, and it appears to be a problem with neural synchrony. So what you see here are two examples of how these babies look when they're being screened with automated ABRs. So for ABR, click stimuli, which are just short duration bursts of sound, are presented at a soft level either through the little insert earphones or in the earphones that go around on the outside of the ear. Responses are recorded via electrodes typically placed on the forehead and in proximity to each ear. And a computer analyzes the responses based on an algorithm. The outcomes are pass or refer, and babies must pass in both ears to pass. So you might ask why, when the Joint Committee recommends using OAs for the first screen in well babies, we and others are using automated ABR for all babies. At Michigan Medicine, it is because we do not want to risk missing auditory neuropathy. Because babies with ANSD have present OAEs, a baby would pass the screening if that technology were used. And we would only discover that the baby had ANSD when he or she has speech and language delays or parents raise concerns about the child's responses to sound. So it would be a late diagnosis. Also, we looked at our own data and found that many instances of ANSD occur in otherwise healthy babies. So the goal of EHDI is to screen all babies all infants prior to discharge. In order to facilitate success at our place, we have technicians performing screens 7 days a week, generally in pairs. One person typically focuses energy on monitoring the status of the NICU babies. For the NICU, screening is ideally conducted as close to discharge as possible because we want them to be as healthy as possible. For all babies who do not pass in both ears, we try to rescreen prior to discharge, which can be challenging since well babies are often discharged within 24 hours, and there are days when 24 babies may be born in our hospital. So even with 2 people screening each day, the volume can be overwhelming. Remember that babies are only screened twice, and babies who refer in 1 or both ears are scheduled for diagnostic testing, typically within 4 to 6 weeks. For NICU babies who are hospitalized for a long time, meeting the 136 guidelines can be challenging. There's a balancing act between waiting until they are less fragile and managing parental and sometimes provider concerns about possible hearing loss. As I said, we will only screen twice, which means if they refer on both attempts, performing a diagnostic ABR is required. Yet, we can't have them come to the clinic until they are medically stable, and the NICU is really not an appropriate environment for testing. In addition, historically, we're not likely to do anything to manage the hearing loss while the babies are medically fragile. On the other hand, some ventilator-dependent babies remain hospitalized for several months or a year or more. For that reason, we're working on a process to test those babies in the operating room when there are concerns and to find a way to provide hearing aids when they're needed.
Jaynee,
Yes.
Emily had a question asking if the AABR test is one where the babies have to be asleep.
Yeah, so we want them to be asleep for ABR, and I'm going to get to that. It isn't so much about the sleep state, it's about movement, as I'm going to discuss right now. Any other questions? Okay.
Nope, not right now.
Okay, cool. So during the diagnostic ABR testing, let me back up to her question. We do have instances where the reason a kid refers in the initial screening is simply that they're not sleeping, that they're moving too much right after they're born. And it still is a refer in any case. So when they come in for diagnostic ABR testing, we're trying to get enough information to fit hearing aids if hearing loss is diagnosed. So in addition to using the click stimulus that we use in screening, we also use stimuli that enable us to test responses across the frequency range that is most important for speech and language development. It is important for the baby to sleep during the testing because muscle movement, which is also electrical signal, can hide the responses that we're trying to record. So we advise parents to bring the baby hungry and tired, so once the baby is fed, he or she is likely to sleep. Again, it's not the sleep state that is so important. It is the lack of movement around the electrodes that is so important. And, that includes sucking and swallowing, which can be an issue for a lot of babies. Distortion product otoacoustic emissions can provide an additional help in the diagnostic testing, especially if a baby does not sleep long enough to get complete ABR testing. Sometimes we're able to get some testing done before the baby wakes up, like for click stimuli, but we're not happy with our ability to address hearing across various frequencies. Because we want to make sure that babies have access to all of the sounds of speech, DPOAEs can help us know that is possible. One of the advantages of DPOAEs as an adjunct to diagnostic ABR testing is that the patient can be awake. And the other is it provides frequency-specific information about outer hair cell function. Tympanometry is another important technology that we use, not for screening, but for follow-up. For tympanometry, a soft rubber probe is inserted into the baby's ear canal. It's essential that an airtight seal is obtained in order to do this test. Sound is presented into the ear canal while air pressure is varied from high to low or low to high. And our goal is to determine whether the maximum movement of the tympanic membrane or eardrum occurs at ambient pressure, meaning at the same pressure as the outside environment. For infants, I mean, you can tell on this picture, it mentions a 220 hertz probe tone. Actually, for infants, we use 1,000 hertz 1,000 hertz probe tone, which is a high frequency, because the ear canal of infants is compliant. If we used the same probe tone we use for older children and adults, we might get results that look normal because we're really moving the ear canal wall instead of the eardrum. Another reason to utilize pediatric audiologists, because sadly there are some audiologists out in practice who don't realize the importance of the probe tone frequency.
Jaynee, we have another question from the chat.
Sure.
Is it safe to assume that the tests that have only one probe are repeated on the other ear as well? That's from Jay.
Yes, we test both ears. Yeah, in fact, for the follow-up testing, even if a baby refers in one ear, when they come in for follow-up testing, we test both ears. And if they don't, you know, if initially they pass in the right ear and refer in the left ear and they come back in and they can't pass in both ears, that's not a pass. So we want to make sure both ears are hearing normally. Any other questions?
Nope.
Okay. So as what was mentioned earlier, the goal from follow-up testing is to rule out hearing loss or to provide enough information to be able to intervene if hearing loss is identified. Our goal is to obtain responses in the normal hearing range for all of the stimuli that we present, including those throughout the frequency range that is most important for speech and language development. If there is hearing loss, we try to use a technique that bypasses the ear canal and middle ear to determine the origin of the hearing loss, or if there's a contribution from the outer or middle ear. That technique is called bone conduction testing. So basically, we're placing a vibrator on the skull and vibrating it, which stimulates the cochlea directly and bypasses any outer or middle ear problems. So by doing both ear conduction and bone conduction testing, we're able to determine if there's hearing loss, what component of that hearing loss might be due to inner ear function, and what component of the hearing loss might be due to something that is perhaps medically treatable, such as something with the middle ear, like fluid in the middle ear. So as was mentioned earlier, DPOAEs and tympanometry can be very helpful. Looking at the middle ear muscle reflex can also provide us with some limited information about nervous system function. So physiologic measures of auditory system function include measures of middle ear function, including tympanometry and assessment of the middle ear reflexes, otoacoustic emissions, and auditory evoked potentials. We've already talked about ABR testing. There are also auditory evoked potentials that can look beyond the brainstem level, but those are outside of the scope of this presentation. Behavioral tests of hearing include assessing an individual's responses to speech stimuli, as well as to pure tones. When we are interested in knowing what is audible or understood through the entire system, we use air-conducted stimuli presented either through earphones or loudspeakers. When hearing loss is present, and we're interested in knowing how much the loss is attributable to the outer and middle ear versus the inner ear and auditory nerve. As I mentioned earlier, we use bone-conducted signals to stimulate the inner ear directly. Procedures with young children are based on operant conditioning paradigms. Response must be something that the child is able to do. What follows the response must be reinforcing to the child, and testing is individualized according to the needs and abilities of the child. So this is just a picture of visual reinforcement audiometry. VRA is typically utilized with children between the ages of 6 months and 18 to 24 months, of course adjusted based on developmental ability. and takes advantage of the child's tendency to turn toward the source of the sound. So by pairing the sound with an animated toy or video image, the child is taught to make a clear head turn toward the sound. The assumption, of course, is that the video image or animated toy is reinforcing to the child, which is a problem if there's a visual impairment, and it can get boring pretty fast. So the goal is to have the child make a head turn response to the sound and not when the sound is absent. And having both the animated toy and video options in our experience can help lengthen the time the child will participate. Here are some picture examples of things you can do for play audiometry. Play audiometry is appropriate when a child is able to sit independently and engage in play. There's nothing magical about the response used during play audiometry other than, again, it must be something the child can do. And you also don't want it to be so much fun that the child wants to do it all the time. Again, here are some options. Some other options include throwing balls in a container or placing puzzle pieces on a puzzle. In any case, the child is taught to make a response to the sound. Reinforcement for play audiometry can take many forms depending on what is motivating for an individual child. Praise is often enough, yet other options might include the use of a token economy or edibles. In a typical test session, more than one game may be utilized to keep the child engaged. There are two types of speech measures that are included in an audiologic assessment appointment. First, we are interested in knowing the softest level at which speech can be detected or heard and understood. For detection, the measure is called a speech detection threshold, whereas the softest level where speech is understood is called speech reception threshold. For speech detection, we can use songs or other speech sounds, and it's fun to walk around our clinic and listen to the audiologists and all of the sounds that they make to get a detection level. It's pretty fun. And they all have their own things they do. For speech reception thresholds, we are typically using two-syllable words presented with equal stress, like baseball, sidewalk, hardware. And we can use picture boards in a picture pointing response. And this is an example of a Spondy board. Of course, some of these pictures are maybe things that kids growing up today don't recognize. Like that's a pretty funny looking bathtub. So of course we need to make sure the child knows all of the names of the pictures before looking for threshold. For younger children, we sometimes have them point to body parts. Speech discrimination is the other measure that we are concerned about, and that refers to how much of speech a child is able to understand. For speech discrimination testing, speech are presented at a comfortable loudness level, and performance is typically recorded in percentages. And we're able to use both single words and sentences for speech discrimination testing. Okay, another polling question. Which of the following is true about physiologic measures of auditory system function? A, they provide information about what an infant or child hears. B, they include OAEs, tympanometry, and ABR. C, they are tools used in newborn hearing screening and follow-up from universal newborn hearing screening. D, they rely on operant conditioning paradigms. E, B and C above, or F, all of the above. Go ahead and record your answers. All right. Well, we didn't do as well on that one as we did on some of the other ones. So 60% said B and C above, which is the correct answer, and 40% said all of the above. And the reason the correct answer is B and C above is that they don't tell us anything about what a child perceives, which is what hearing is, and they do not rely on operant conditioning paradigms. So here's another polling question for you. What is true about behavioral measures of hearing? A, they provide information about what a child hears and understands. B, they include testing using tonal and speech stimuli. C, procedures are modified according to the needs and abilities of the individual patient. D, they are appropriate for infants and children of any age. E, A, B, and C above, or F, all of the above. All right, we did a little bit better on that one, actually a lot better on that one. So 82% of you said that it was A, B, and C above, which is the correct answer. The reason it's not all of the above is that we're not able to use behavioral techniques for infants. Remember, VRA, which is the technique we use for the youngest children, starts at about 6 months of age. So we've talked about how we screen and test children. Of course, once hearing loss is identified, rehabilitation options for individual babies depends on the goals parents have for their children. When that includes use of spoken language as the primary communication modality, hearing aids are fit as soon as possible, ideally once hearing loss is confirmed. We are really lucky at Michigan Medicine to have a supply of pediatric hearing aids that were purchased using donor funds, so there are no barriers to fitting hearing aids, even while insurance situation is being resolved, which can take a while. Happily, in Michigan, all children with permanent health condition, including hearing loss, are eligible for Children's Special Health Care Services, which provides hearing aids every 5 years, as well as ear molds and batteries. However, the enrollment process for Children's Special Health Care Services can take a while. So having these loaner hearing aids enables us to move forward quickly. And we were just lucky to connect with donors who just wanted to make a difference in the lives of children. And so their only ask was that we periodically tell them stories about how their donations are making differences. So quarterly, we put together a book of all the stories of where these loaner hearing aids have gone. Of course, the goal of amplification is to make audible all of the sounds of speech. So for kiddos who have persistent conductive hearing loss, bone conduction devices are often the treatment of choice because they bypass the outer and middle ear to stimulate the inner ear directly. They are particularly useful for children with congenital ear deformities, as you can see in the pictures, such as the absence or distortion of an external ear in microtia, as well as for very narrow or closed ear canals. In young children, these are typically fit, they are always fit on an elastic band, or now there are modified ball caps that the device can connect into. For older children and adults, implantable devices are options. So the processor is the same, which is that little button-looking thing, but it is attached to a titanium screw that's implanted in the bone of the skull. When hearing loss is so severe that it is impossible to make all of the sounds of speech audible with hearing aids alone, cochlear implantation is recommended. Again, providing that the goal for the child is spoken language. Cochlear implants may also be appropriate in children with auditory, with ANSD or single-sided deafness. In Michigan, most insurance companies will not cover the cost of implantation until 12 months of age. So all kiddos start out with hearing aids. Exceptions include the case of bacterial meningitis, because there is a risk of cochlear ossification, which can prevent full insertion of the electrode array. For those children, the candidacy process is fast-tracked, and simultaneous bilateral implantation is typical. For other children, some children are implanted bilaterally during a single surgery, while others continue to use a hearing aid in 1 year, or may be implanted serially. So 1 ear first and then the other ear later. Inclusion of a speech-language pathologist on our team is so important. We rely on our speech-language pathology colleagues to help facilitate success. They are able to monitor speech and language development following intervention, which plays a huge role in considering moving from hearing aids to cochlear implant. For example, if a child is not making the progress that is expected, they can influence the decision to change technologies. They are also able to reinforce with parents the importance of a child wearing amplification during all waking hours. Finally, providing training to parents regarding what they can do to reinforce listening at home is important. For children with hearing loss, they need a speech-language pathologist who specializes in working with children who are deaf or hard of hearing. I think it's really important to stress that time lost is time lost, which is the rationale not only for early identification of hearing loss, but also early and appropriate intervention. A child with hearing loss needs to have the same number of exposures to language as does a child with normal hearing in order to develop language. Sometimes parents and others think that if a child's hearing loss is diagnosed late at 18 months, he or she will start talking once we fit hearing aids. Unfortunately, the day speech becomes audible is essentially the beginning of the child's hearing age. So, 18-month-old is missed 18 months of exposure. Also, the length of time it takes to develop language depends on the child wearing amplification during all waking hours, as well as being in a language-rich environment. Unfortunately, we're able to track hearing aid usage. Parents might come in and say, oh, my child wears their hearing aid all day, and then we can look at how much they're really using it, and it's 4 hours. So in summary, there are several variables related to success for a child with hearing loss. The first is the age of intervention, as mentioned before. The cochlear status is also important since there are conditions that result in progressive hearing loss, such as enlarged vestibular aqueduct syndrome, or EVA. Some of these same anatomical conditions can negatively impact the success of hearing aids or a cochlear implant. As we discussed before, children with hearing loss may need to rely more on their cognitive skills to succeed than do children with normal hearing. Parental motivation and involvement are key. It takes a lot of energy to make sure a child is wearing amplification during all waking hours, especially during certain stages of development. Picture your typical 1 or 2-year-old and what things they can get into. It also takes effort to create a language-rich environment at home. Finally, educational placement and support are so important because these children need a language-rich environment all day long. It is important that the placement provide a program that is concentrated in auditory skill development. Children need to learn to listen. Listening is not automatic in children with hearing loss, particularly when the use of visual cues is so much easier. Of course, there are other variables that impact a child's success in achieving the goals that parents have for their child, particularly if they include the use of spoken language as a primary modality. In terms of hearing loss, it's trickier to provide appropriate intervention when the hearing loss is fluctuating, which is often the case with auditory neuropathy and enlarged vestibular aqueduct, because the amplification needs change. Many of the children we see also have other comorbidities, such as heart defects, vision impairment, being dependent on a ventilator, or neurodevelopmental disabilities such as autism. Each of those factors complicates things for the parents and family, and sometimes hearing loss is not the highest priority for the family. We also see patients coming from complex family situations, including homelessness, parental drug abuse, domestic violence, and foster care, each of which can negatively impact a child's access to amplification and educational programming. Connecting families with support systems is so important to the child's outcomes. The Joint Committee recommendation is that all infants who pass the initial hearing screening but have a risk factor for progressive hearing loss have at least one diagnostic audiology assessment by 24 to 30 months of age. They also recommend that early and more frequent assessment be indicated for children with congenital CMV, syndromes associated with hearing loss, children who have received ECMO or chemotherapy, family history of hearing loss, and when there is caregiver concern. And there it is again, caregiver concern. So now I'd be interested in hearing your thoughts about the timing of the first audiology diagnostic assessment for all others with risk factors. Please raise your hand to comment. And specifically, I'm asking, if we wait till 24 to 30 months of age to provide a first hearing test, how might that impact things?
Kayla, go ahead.
I'm just thinking like they've already begun speaking and babbling and starting to form these words. So if we wait that long, we might miss out on some early intervention time that could have been completed just from the SLP perspective.
Great. Anyone else?
Sandy, go ahead.
Well, having one with a hearing loss who didn't get her hearing aids until she was 2, we played catch up on speech for, she's 16 now, so for probably 13 of those years. So it's crucial that these kids get fitted and get some amplification as soon as possible.
Yes, Claire, go ahead.
Yeah, so clearly that's a really long time to wait till the kid's 2 or past that. We know that the critical period is up to age 3, so that's the majority of that time. And there's no way to know when that hearing loss might occur, since the newborn hearing screening could, might be done the week after they're born or not, even before that. And so there's all of this time that it's kind of unaccounted for, that you can't quite pinpoint when that hearing loss might have happened.
Great. Anyone else? Okay. Well, so in our clinic, our protocol is to do follow-up testing at 6-month intervals for all children with risk factors for progressive hearing loss. And we do that until they're 4 years old, at which time the school should take over. And for exactly the reasons that you all indicated, it's just too long to wait. You don't want to wait until somebody's speech and language isn't progressing like it should to figure out that there's hearing loss. I'm going to skip this one. Just that, as you mentioned, there are a number of concerns related to the impact of the Joint Committee recommendations in terms of timing, as we've outlined. And here are some others. So, again, potential delay, negative impact on speech and language. You guys did a great job. Also, looking at our data, I keep mentioning that we keep track of our kids. So a review of our data suggested that over half were identified before the age of 24 months. So maybe if we switch that timing a bit, we would be able to identify them. And as was mentioned, you can't determine the timing of the hearing loss onset for those who are identified later. And again, caregiver concern has been cited as a really big reason to complete diagnostic testing. So thoughts and possible directions. While the current recommendations reduce the number of monitoring appointments needed for children with risk factors, which might improve follow-up with recommendations and reduce confusion about a recommended protocol, it may also result in late identification of hearing loss. In addition, if testing is not recommended until 24 months, parents may discount the importance of a hearing test or forget that monitoring is recommended. And that's especially true when, as somebody indicated earlier, some primary care physicians just say, oh, don't worry, it'll come, it's not a big deal. So if the recommended time window was changed to 12 to 18 months, our data suggests that a majority of late onset hearing loss would have been identified within that time frame. And then hearing loss with an onset after 18 months is likely to be suspected by parents and primary care providers due to its impact on speech and language development. So as individuals who are pursuing or in a career in the healthcare field or working with people with neurodevelopmental disabilities, including autism, you can help ensure that children who might have hearing loss are referred to an audiologist. For family members of individuals with neurodevelopmental disabilities, it's important to consider whether hearing loss may be a contributing factor to success or lack thereof. Referral to audiology is recommended whenever there are concerns about hearing or speech and language development, as well as when the child's development is lagging behind. Consideration of hearing as a possible cause for declining school performance is also important, as is a child's complaint about having trouble hearing. So when in doubt, please refer. So I want to let you know that we have been fortunate in our clinic to add a patient and family centered care coordinator. 3 years ago, we hired the mother of a child with hearing loss into that role, and her role has evolved a bit over time. We knew that although we were able as audiologists to talk with parents about their child's hearing loss and what we would recommend in terms of audiologic management, we were not able to empathize with what they were feeling and thinking because none of us has a child with hearing loss. So having Jen on our team is great because she went through the denial process with her son. She did not believe he had a hearing loss until she threw pans on the floor or something like that. And she experienced the guilt of delayed follow-through. She also watched his hearing loss progress. He wore hearing aids initially, and then she had to make decisions about cochlear implantation. And since her son is doing incredibly well, she is able to share success stories from a parent perspective. So today, Jen makes the initial follow-up contact with families post-diagnosis and occasionally participates in clinic visits, especially when parents are struggling. And over the past year, she has taken the lead in helping us develop an interprofessional education program for parents of children with newly identified hearing loss. So we do that quarterly and invite families to come, and they hear from a number of professionals. So having Jen on our team has had a profound impact on the success of our newborn hearing screening and follow-up program.
Jane,
Yes.
we have a question from John. Do you ever run into families in which the child fails an initial neonatal diagnostic and the parents do not follow up? I have met several deaf parents who prefer their hearing child to join the deaf community.
Yeah, so, I mentioned that we're supposed to present information in an unbiased manner. It's hard, honestly, being an audiologist to, when we know what technologies are available, to not have a bias about what we would like for families to do, but we do have families who choose not to intervene in terms of hearing aids. That really limits them a lot because there are limited educational programs now for people who don't have auditory skills. The deaf school in Flint is the primary option. We actually have had hearing parents, oddly to me, elect not to intervene. And it's sad when you know that these kids had hearing loss that was only moderate and could have been easily amplified. So it does happen. We also have families, though, that are in complete denial. So, and some of that can be culturally based, where either there's a religious component that causes parents to want to wait to do anything because they believe that, there will be healing that takes place. In some cultures, it's difficult for families to admit that there's anything wrong with their child, and so they don't want to intervene. So we do have those challenges, and we just try really hard to be sensitive and to honor the family's wishes while providing information about, this time lost is time lost. So getting language in somehow is really, really important early. Imagine how frustrating it would be if you had no ability to communicate your wants or needs to those around you. So, but it does happen.
But another question from Sandy. She asked, does toxoplasmosis have an effect on hearing with adults?
Toxoplasmosis is a risk factor when the mother is exposed when she's pregnant to toxoplasmosis. So it's an in utero exposure risk.
Christine had a question. What factors go into deciding whether both cochlear implants are placed at once or if one is done later than the other?
So other than for bacterial meningitis, I think it's really parental. Well, it can be insurance driven, and then it can be parental preference driven. Our neurotologists used to be biased against doing bilateral cochlear implants because they risked, you don't know if you're going to make it a lot worse, but with what they're calling now soft insertion, so being able to insert an electrode array without really damaging the part of the cochlea that's not damaged, I think people are leaning, it's just changed their biases. In places where insurance isn't a problem, I mean, at the Mayo Clinic, they implant 6-month-olds, and, so practice, I think, often is driven by what insurance will pay for.
Brittany had one other one. She says, this may sound stupid, but how do the aides monitor the time the child wore their aid?
Oh, because it's part of a computer chip that's in the hearing aid. And so it can detect when the hearing aid is getting sound into it, turned on and getting sound into it. So, it's a useful tool for counseling parents who, and they may, in some cases, they may think that they're doing a better job than they are.
So my question is about, for chronic ear infections, how does that affect and damage hearing? I understand when fluid builds up, it muffles the sound, but how does that lead to damaging effects?
Well, chronic middle ear pathology. So first of all, if fluid in the ear can be caused by a eustachian tube dysfunction, it can start out as clear serous fluid. If it stays in there for a long time, it can get very thick, mucoid-like, and then that causes more hearing loss. It can also, if it's in there for a long time, damage the bones that are in the middle ear. Also, there's a condition, cholesteatoma, that is a growth of basically skin cells that can get into the middle ear space, and cholesteatoma can erode not just the ossicles, so the bones of the middle ear, but it can erode the skull itself. And if not, I mean, that is a mandatory treat thing. That's not optional surgery, really, because you can wind up getting your infection spread to your brain.
None at the moment.
Okay. So in summary, we're really actually doing a good job of making sure babies are screened prior to discharge and in ensuring timely follow-up for those who do not pass the initial screen. In Michigan, the EHDI coordinator does a remarkable job of tracking down families who do not come in for diagnostic testing following a failed screen. We are also, in our place, doing a good job of identifying hearing loss by 3 months of age. Although lately it seems like we have been testing 4-month-olds and 5-month-olds that got lost to follow-up somewhere. Although there's variability from state to state. The loss to follow-up rate is decreasing. One of our strategies is to schedule follow-up appointments prior to discharge and to make reminder calls for every diagnostic ABR that is scheduled. We also invest energy to call every family with instructions for testing, including bringing the baby hungry and tired to the appointment. Generally, once the baby is fed, natural sleep occurs. Our loaner hearing aid bank helps us fit amplification shortly following diagnosis, and our PFCC coordinator helps get families connected with early intervention, such as early on. Having said that, our relationships with primary care providers are critical for the success of our EHDI program. Not only can they reinforce the need for follow-up testing, they can monitor developmental milestones and make referrals when delays are noted. And here's your final polling question. Elements that are important to a successful EHDI program include A, universal newborn hearing screening, B, followed by a team of pediatric audiologists, C, active involvement by the medical home, including ongoing surveillance, D, parental involvement and consideration of their goals for their child, E, appropriate early intervention, and F, all of the above. 100% correct. Yay! So as you all know, the correct answer is all of the above. Kudos. So thanks for your attention to this presentation and for your participation. The CDC site has some great information about hearing loss. There's also really good information in the materials that you were given. There's a ton of resources about EHDI, about all kinds of things. So I hope you'll keep those in your hip pocket and make reference to them whenever you need to. I'd be interested in knowing from you all whether you think this sort of presentation provides you useful information that you can relate to in your own disciplines.
Emily says yes in the chat. Sandy said absolutely.
Oh, good.
Mm-hmm.
I forgot to raise how to raise my hand, so I'm just gonna interrupt, I guess. But I actually work at Michigan School for the Deaf, so this actually helps me a lot to understand the kids because my focus is nutrition actually. So this helps me understand the kids that I actually work with every single day. And what they have gone through and what the families have gone through every single day as well. So I appreciate all this information and your time.
Great. Thanks for the feedback. Any other remaining questions about any of this content or audiology in general?
I don't see any right now.
Okay. Well, you're getting finished a little bit early. Again, I really appreciate your participation and thank you so much for your attention.
Yeah, thank you, everybody. Look for an evaluation of this session in your inboxes very shortly. The next session will be on Tuesday, February 27th, and it'll be the second Zoom session for Module 9 on audiology. And we'll have Teresa Crumpton will be presenting on that night. So thanks again, and happy Valentine's Day, everybody. Have a great week. Yes.
Michael? Can I just put in a plug for those of you who have not yet done any audiology observations? Please make plans to do that. It'd be unfortunate if you wait till the end of the year. And for those of you who have contacted me to schedule time at Michigan, I appreciate that.
Yes, absolutely. So if you have questions about that, please, you can email Jaynee or Ann or myself, and we can get you that information. And it is up in the folder on Blackboard labeled Clinical Experiences.